Well, I think we should get started. I think today's speaker probably needs no introduction, especially to this group, but I'm going to give him a little pain by introducing him anyway. Mike Cohen is the J. Herbert Bay Distinguished Professor of Medicine, Microbiology, Immunology, and Public Health, and I think that summarizes his career quite well. He, within the last year and a half, was also appointed as the Associate Vice Chancellor for Medical Affairs and Global Health. I think Mike is best known to many people, at least in the Department of Medicine, as the very distinguished leader of the Division of Infectious Disease, a division that has done outstanding work in many areas, clinical care, certainly clinical teaching of our residents and fellows, and certainly in research, and the research, as all of you know, has really developed a global outreach that's rather amazing. Mike's own personal research interest is in the area of HIV transmission and in the prevention of HIV transmission. And as you all know, he's done landmark studies looking at the biology of HIV transmission and the use of antiretroviral agents in prevention of transmission, and also has really done a lot of work in resource-constrained countries. And as you know, there are now centers in Malawi and in China and in areas I'm sure I'm not even familiar with. So today Mike will discuss the HIV pandemic. Where do we go from here? And I'll turn it over to him.
Thank you, Andrew. So let me, before I even start, make a bunch of paid advertisements that Charlie Vanderwerf has put me up to. So let me get them straight. First, tomorrow at 8:30, Lynn Moffinson, who's a really huge leader in prevention of transmission of HIV from moms to baby, will speak at 8:30 a.m. in the Lineberger first floor, they're now called the Pagano Conference Room. So that was named after him last month. So I would encourage anyone interested in that topic to show up, and show up early because that place is always incredibly overcrowded. Second, Charlie has arranged a dinner that he'll advertise more widely for residents who are interested in infectious disease. This is the first time we've ever done this. You'll announce it through the Department of Medicine, when it's going to be, how it's going to be, and Charlie's going to pay for it himself. So it's a very exciting dinner. He's not charging Joe. I don't know if Joe realized here, but Joe's not paying for it. The third announcement is at the end of the month, those interested in China, this talk we'll have today will be very global. There'll be a big meeting. UNC was participating with the government of China in a meeting a year ago in Beijing, a health forum in China. That meeting will be held at UNC in the Global Education Center at the end of this month. There'll be a lot of announcements about it. I would encourage anyone interested in healthcare in China to show up. Okay, that's the paid advertisements. Now we'll go forward. So we're going to talk about, and I talk really fast, so if it's beyond understanding, too bad. So we're going to talk about three topics: the pandemic, global treatment, and prevention. And this is going to be incredibly hyperbolic and braggadocio, which is kind of not inappropriate, because UNC is one of the great centers for HIV research in the world. We're ranked 8th by U.S. News and World Report in the graduate student issue last year as the 8th best place, I would say, in the world for this kind of research activity. And because I'm not going to thank everyone who participates in this, because a lot of people do, I just want to particularly point out Ron Swanstrom, who's here, who runs the Center for AIDS Research, who most of you don't know, raise your hand, Ron. Most of you would never know Ron Swanstrom, who runs this center that's been very important to our activities, and Angela Kashuba, who most of you would never know, raise your hand, Angela, who's the leader of our pharmacology group, and they've been really critical in a lot of our work beyond a lot of people you already know. So the first issue is this little tiny report in MWR about a few gay men having pneumocystis, and this is in 1980-81 by a guy who's no longer really in this field. And this little report went noticed by all of us, but no one ever anticipated, I don't think at that moment in time, that this would be the pandemic of the 21st century. To start with the narcissism, here's me living in China at the time of the report, and you'll notice I have hair, a lot of really good hair, and my wife Gail Henderson is still in the faculty here, sitting next to me, and we still work in China. And China, I won't say much about today, but remains a key interest of UNC faculty. So the HIV epidemic is a big deal. And there are anywhere between 36 to 50 million people who've been infected and 16 million people who have died. Most of the infections are not in the United States or in Europe. Most of the infections are in resource-constrained places, and especially sub-Saharan Africa. Virtually everyone's familiar with this kind of a slide. HIV is not going to go away in your lifetime. It's going to stay in Africa over the lifetime of everyone who's in this room. So there's no possibility that this will not continue to devastate Africa over the next 20, 30, 40, or 50 years. HIV is hyper-endemic in India. No one really knows the true prevalence. There's always a huge debate because surveillance is so difficult. In countries that have 1 billion people, you're not going to go door to door to understand the prevalence. But India has a big problem, millions of cases of HIV. China probably has about 1 million cases of HIV and might not have a giant epidemic. Russia has a fairly aggressive epidemic because of intravenous drug use. These 3 countries will help to define how big the epidemic gets above and beyond Africa. And then other countries could become involved, but I think the game is in the areas we're talking about. There are about 14,000 new cases a day of HIV. 95% of these cases are in resource-constrained countries. Many of the cases continue to occur in children, neonates being exposed during delivery. It's worth noting that Susan Fiskus and Charlie Vanderhorst and the AIDS group here, working with the state, made North Carolina a real model of preventing HIV transmission from moms to babies. So in the state of North Carolina, I don't know the exact number, but there are a very, very small number of babies born with HIV. You've got to juxtapose this in the United States against other states. New Jersey maybe is one of the best examples, or New York State, where ongoing transmission events have forced laws making testing mandatory among moms in those states because of the ongoing transmission from moms to babies. So North Carolina has done a great job of this with the help of the people on this faculty. There are about 12,000 to 14,000 are people 15 to 49, and about half of these are adolescents or early adults. So the future of the epidemic can also be defined in terms of where is this all going. It's going to continue to attack people who are just reaching reproductive age. And of course, in developing countries, women want to have babies oftentimes at much earlier ages, and that puts a great pressure on them to get pregnant and not get HIV. So that kind of pressure creates a tension that cannot be overcome no matter how much we talk about our prevention activities, because you can't have the baby unless you have unprotected intercourse. About 4 new people get infected for every person treated. This is important as we talk about treatment, because we cannot treat our way out of this epidemic. And the realization that that's not possible has been important to the United States in particular. What about the United States? I talked a little about global demographics. In the United States, the epidemic is actually fairly constrained. Maybe 800,000 to 1 million people infected. About half to 2/3 know that they're infected. About half don't know they're infected, and that continues to plague us because people come to the emergency room with very advanced disease who could have been saved from the complications and consequences of the advanced disease. Again, North Carolina is trying to lead the way and to create an environment where we know everyone's status who's at risk and prevent presentation with advanced disease. Most of the disease persisting in the United States is in men having sex with men. You see the yellow there is 67% of the cases among MSMs, and this epidemic of MSMs is getting bigger, not less, in the United States. It's being driven by a lot of factors, including social forces that we only poorly understand, and including the use of methamphetamines as club drugs. Chris Hurt, Joe Ray, and others in this group, and Lisa Hightower, are aggressively studying these use of club drugs. Now, the really terrible social forces that have created an environment where there's a lot of African American men, both gay and straight and bisexual, are incarcerated or otherwise unavailable. So African American women often are put in a situation where there are fewer men available for lifestyle choice or for the future than would be available in a society that was a little bit different. That is creating an environment where we're seeing an epidemic of HIV in heterosexual African American women, especially in the southeastern United States. And this is shown graphically here. You see this is minority or African American women. You see this massive rise of number of cases who are acquiring this disease through heterosexual intercourse from infected African American men. There's a lot of social forces that lead to this that are beyond our discussion today. Ada Adamora has been one of the really big leaders in studying this problem with other people in our group. So that's the kind of demographics of HIV. A massive problem for the world, a modest but serious problem for the United States. So how do we get there? Well, there's this, how many of you know this formula? How many don't know this formula? Tell the truth. How many don't want to know the formula? This is the big formula for us. Rho equals beta delta C. When rho is greater than 1, epidemics continue. How do you calculate rho? If rho became less than 1, this epidemic would go away. Rho is calculated by multiplying the efficiency of transmission of HIV. It's a biological event. You don't get a little infected, times the duration of infectiousness of the person who's HIV infected, times the number of people they've exposed. So if you multiply these three factors together, you get a feeling for the epidemic. So we've got, our concern at UNC, to a great extent, has been on the efficiency of transmission, and I'll talk about that in more detail. But you've also got to be concerned, if you want to prevent HIV, in reducing the duration of infectiousness, and if you're a behavioral person, you're trying to create an environment where fewer people are exposed, where somebody knows their status and doesn't expose the next person. In fact, the biological requirements for transmission of HIV are very straightforward. There's infectiousness and susceptibility. Infectiousness can be identified, can be understood by looking at two factors. How much virus is there? This is the 900-pound gorilla. The concentration of virus will help to determine whether a person is very infectious or not infectious. So for an infectious disease specialist, what we're about is trying to reduce the concentration of HIV available to infect the next person. The other point is that HIV is divided into subtypes called clades. The clade we have in the United States is almost universally type B. That type B HIV appears to be considerably less contagious than the type they have in Africa, which is type C HIV. We don't understand the difference of type B and type C, but that's a hot area of research. So you've got a person who's infectious, who either knows their status or doesn't know their status, and their infectiousness will depend on their inoculum. And then you've got susceptibility. Not everyone is equally susceptible to HIV. First of all, some people have hereditary resistance. About 1 in 100 white people have a deletion in the receptor that likes HIV, called the CCR5 receptor. So 1 out of 100 white people in this audience would be unlikely to be infected when exposed because of this deletion. Now, this is much less common in people of color. Less than 1 in 2,000 people of color have the same deletion. So people of color are put at a biological disadvantage for this virus. What does this deletion do? How did it occur? No one understands it. There's innate resistance that we don't understand at all, and there might or might not be any acquired resistance. Some people think that there's a small number of sex workers living in Nairobi, in a particular place in Nairobi, who keep getting exposed to HIV and never get HIV. And it's claimed that they might have acquired resistance. But no one has ever duplicated this finding, and this finding has never helped us at all in making a vaccine. So I'm very skeptical about acquired resistance. So now we're down to the biological requirements of infectiousness and susceptibility. And then we look at epidemiology. And what happens with epidemiology is pretty straightforward. That we got 3 routes. By the way, can you understand me at this rate of speed? I'm limited by my need to take a breath. This is like basically, I have like 70 slides. To get through 70 slides requires no breathing. There's 3 routes of transmission: the sexual transmission, the parenteral transmission, and transmission from mom to babies. We know from parenteral transmission that a unit of blood is 100% infectious, and a needle stick is much less infectious, and a needle stick with a suture needle is almost not infectious at all. So the inoculum is kind of proven in parenteral transmission. We know transmission from mom to baby can occur during pregnancy, during delivery, after delivery, and through breast milk, and we know that antiviral therapy at different times can interfere with this transmission event. So this is a great example of the use of a drug available to us for massive public health benefit. And the talk tomorrow by Lynn Moffinson is going to be all about this, and Charlie Vanderwich has led, I think, the world's biggest study called BAN to try and understand optimal interventions with antiviral during pregnancy and following delivery. And that study result will be finished this year. Is that correct, Charlie? Now, the sexual transmission is a really big problem. 90% of all transmission is sexual in nature. This is not an epidemic about drug users. This is not an epidemic about gay men. On a planetary basis, this is an epidemic of people living their lives in couples where one partner is infected and the other partner is not infected, and the uninfected partner doesn't realize they're being exposed to the infected partner, and a transmission event occurs. And so we've tried to understand this transmission event in terms of the probability of man to woman, woman to man to woman, woman to man, which would require anal intercourse and fellatio. And the problem is that these numbers are just wrong. And I criticize the author. I was the author of this article. So the author is like a total idiot. And I would say, I don't want to explain my idiocy. It seemed really smart at the time. And this article has been cited like more than 1 million times. And I could say it's like really, really wrong. Because in the end of the day, don't raise your hand for this, but most people don't have 3,000 episodes of intercourse. Not easily at least. And I don't want to make this too I don't want to make it too personal. So I'm going to don't raise your hands for anything. But we know from studies done all over the world about sexual behavior that every person in our species, based on age mostly, has sex about the same number of times a month. Most young people who are sexually active have sex about 10 times a month. And as you get older, this kind of trails off, and you see how we lump 35 to 60. Because this gets so low, it goes below the line. Because some people are telling other people, like me, not to have sex. And so it's a very steep curve. But in younger people who are at risk for HIV, they're having intercourse about 10 times a month, about 80 times a year. Well, if it took several hundred or thousand episodes of intercourse to have a transmission event, you could never sustain an epidemic with 36 million people infected. So we went really, really wrong, and I'm not going to tell you all the ways we went wrong, but it forced us to reconsider our thinking. So this is the hypothesis, which is pretty much written in stone now. I would say it's no longer a hypothesis. Transmission rates are too low to explain the epidemic or the pandemic. Transmission must be intermittently amplified, and it's amplified by one thing: increased shedding of HIV in the genital tract. That has to be the way the virus goes from one person to another. Amplified transmission explains the pandemic, making the biological transmission much more efficient, and other sexually transmitted diseases, the classical ones, will play a role, as I'll show you in a minute. So when we talk about the transmission event, we again come down to our two parameters: infectiousness. We're concerned about how much HIV there is in the blood, how this translates into the genital tract, what the stage of infection is, for reasons you'll see in a second, whether the genital tract is pristine or ulcerated, whether there's other sources of inflammation. These factors will help us to determine whether you as an infected person are more contagious or less contagious. For the susceptible person, we'll have acquisition. And the acquisition probability is going to be determined both by hereditary and innate and acquired resistance we've already talked about, but also by what the genital tract looks like. Are there ulcers? Are there inflammatory STDs? Is there cervical ectopy? That probably plays a role. And then other factors that play an important role as well. Now for acquisition, we'll have to be concerned about circumcision, and I'll come back to that later. So this slide is important to our thinking. This is big idea one. Transmission occurs in clusters. And there's a lot of evidence that what transpires is as follows: that a person's HIV negative, and when they acquire HIV, they have uninhibited replication of HIV to a very high copy number. So this is the genital tract, and these are actual numbers that we've measured. I'm sad or glad to say that our group has collected thousands of semen samples and measured. I mean, it's not that easy to collect these. And so because you don't give at the office usually. And so we've collected these thousands of samples, and we've actually measured the concentration of HIV in semen in many different circumstances. When you first acquire HIV, you've got unrestrained replication of HIV, and for several weeks, maybe 3 to 4 weeks, you have a very high copy number of HIV in your semen, and if you're a woman, you have a very high copy number in the female genital tract. Then you have restraint of HIV replication. We don't understand that restraint. The restraint is immunological in nature, but it's also genetic in nature. And so there's very strong evidence that your genetic background helps to determine whether you go on, after you restrain HIV, to have a high set point, in which case you have more virus in your blood, you're more contagious, and your disease progresses more rapidly, or whether you have a low set point. What's shown here is somebody whose set point is so low that they probably cannot transmit to the next person. That would be called an elite controller, somebody whose genetic and immunological basis allows them to stop the replication of HIV. People who control the virus at this very low level go on to live very long periods of time and probably do not infect the next person. So the transmission probabilities from somebody with acute infection, it probably takes less than 30 episodes of intercourse for a person who's infected to infect the next person. Somebody with a very low set point of HIV, less than 1,000 copies in their blood, it would take thousands and maybe 10,000 episodes of intercourse for a transmission event to occur. And then as HIV turns into AIDS and the viral load in the blood goes higher, which is the event that brings the person to the emergency room, that same person has gone from being non-contagious to being much more contagious. So the extremes of HIV are when transmission occurs. During acute infection, and it's estimated that maybe as much as 42% of all new cases have occurred from somebody who just got HIV. So when we find one person with HIV, we go on a massive hunt for other people exposed. And then we find other people with acute HIV. So acute HIV to acute HIV to acute HIV. This is a clustering phenomenon. And some HIV, of course, maybe 16 to 20% is transmitted from people with AIDS, who are still sexually active, don't necessarily know their status, and have a transmission event. Now, when you wonder about the epidemic, remember, most of our resources have not gone to acute infection. They've not gone to secondary prevention in the clinics. In fact, we were blocked from doing prevention in clinics until recently. This is a sad story, but the Ryan White money available to run HIV clinics could not be used for prevention until how many years ago? Who knows? 3 or 4 years ago. We were blocked by law from doing HIV prevention with the money we had from the federal government. Most of our energy has gone into people of unknown status, kind of in the middle. Not the best public health strategy. Another thing that's important is classical sexually transmitted diseases. Here's a person with acute infection who's now restrained their virus. Now they have a very low copy number, but they remain sexually active. Now they get gonorrhea or chlamydia or syphilis or something else. They replicate HIV in their genital tract to a higher level, and they become more contagious again. So when we see, and about 10% of people who come to our clinic have untreated STDs. So people with HIV go on and get more STDs, and they become more contagious again. When we've given somebody antiviral therapy, it doesn't mean we prevented them from breaking through the antiviral therapy when inflammation occurs. So some people who get antiviral therapy and get an STD recur a high concentration of HIV in their genital tract, become much more contagious, and oftentimes the virus that they've recovered in the genital tract, developed in the genital tract, is now resistant to the antiviral drug. So that's a big parameter to watch out for. So the classical STDs, there's a lot of them, almost 400 million a year globally. Most of the classical STDs are in sub-Saharan Africa. So if you want to study the relationship between STDs and HIV, you're not going to do it in North Carolina. You're going to look in Africa to find the intersection of the two problems, STDs and HIV. And the STD we're going to be most concerned about, and I'm sorry for the graphic pictures, this is a penis. And so, Phil, I apologize to you. So the differential diagnosis of genital ulcer disease includes chancroid, syphilis, and herpes. But herpes is the 900-pound gorilla. Herpes viruses fill the species, and HSV2, about 1 in 5 Americans have unrecognized HSV2. Only about 1% of Americans with HSV2 have symptoms of HSV2, that is blisters and ulcers and recurrent HSV2, but 50 million Americans or more shed HSV2 and have antibodies to HSV2. And in Africa, 80 to 90% of all sexually active Africans have unrecognized, untreated HSV2. So a big player, we believe, in HIV transmission is untreated HSV2, causing inflammation and making people more susceptible. Now, this is the motto of the state, to be and not to seem to be. And I think in global activities at UNC, that's particularly important. Most universities are trying to globalize. It's really important to know that UNC has 20, 30, 40-year history of working in many, many countries. So all the countries that UNC faculty, not just the School of Medicine, all the faculty work at UNC, they're all recognized here, but we have a particularly strong profile in South Africa, and in the Congo, and in Madagascar, and in Thailand, the Philippines, and China. lots and lots of the research dollars that you see listed on our NIH ranking, which is now 10th, by the way, which is a huge thing that we're now ranked 10th, I call it 10th. Gene says 11th, but why would you not want to round off? Gene, you round in the next number. What's wrong with you? This is why there's no future for you. This is why your future is very limited. A person of vision would have rounded off immediately. The issue for us is Malawi. We've worked in Malawi, a sub-Saharan African country, for 19 years, so we're not going anywhere. We work in Malawi because it's a country where we can learn a lot about HIV transmission, especially the effects of STDs on HIV transmission. So it's a country of 10 million people, 90% rural, second poorest country in the world with a per capita income of $200 a year, rounding off, Gene. 900,000 people are living with HIV, which is a real tragedy, about 15% adult prevalence. But we run an STD clinic where about half the people who come to the STD clinic on a daily basis are HIV infected. So you come with an STD, we can see the intersection then of STDs and HIV every day and do many, many studies quickly. This is what thatched huts look like in rural Malawi. We have a research center that was literally built by a guy named Irving Hoffman, who many of you know. He's an associate professor in this department. He's just a terrific leader, and he, over all these many years, has worked on this program and helped build this building, which we call Hoffman Estates. So this is like the research building that we occupy on the grounds of the hospital, called the Tadziri Center, and is working together. This is the auditorium, which is the largest kind of medical auditorium in the city of Lilongwe, which is the capital of the city. This is the state-of-the-art laboratory that we have that really allows us to function as an NIH center in Malawi, and we have fantastic personnel, many of whom have trained here with Peter Gilligan. Raise your hand if anyone doesn't know who you are. Peter's been a terrific collaborator, allowing microbiologists and other people from Malawi to train in his laboratory real selflessly, never demands anything truly, except basketball tickets probably. And the thing that we're actually most proud of, the most amazing thing is that the librarians at UNC, and raise your hand, our library colleague, the librarians at UNC adopted Malawi, and what they did was set up a virtual UNC library here. So this is the old homepage of UNC in a library where there's a trained librarian with 6 computer terminals allowing the people of Malawi to use the UNC library online. And it's like the most amazing thing of all time, and brings tears to our eyes. And we can't thank the library enough for this effort. This is the kind of work we've done. This is our most recent publication. So why am I telling you all this? It's like Malawi is a metaphor for how you can study HIV. Malawi is also an example of how UNC is a global university, and how our future, to a great extent, research is conducted on a global stage, not a local stage. So if we're going to be competitive in HIV research and HIV interventions, we have to work globally, and that's why we embraced all this work in Malawi. This is a really important paper by Chris Pilcher, published this year, in which we actually collect semen specimens from people in Malawi with acute infection. In our STD clinic, we see 1 acute infection a day, basically, or every other day. We capture the person with acute infection, we get their blood and their semen, these are men, and we see the actual concentration. And what's interesting is the blood copy number shown here comes down to a level that's very high relative to an American, between 10 to the 5th and 10 to the 6th copies. The semen concentration is very high the first time we measure it, and that transmission probability is about 1 in 30, as I said. But by 16 weeks, while the blood remains high, the semen has dropped to a level where transmission will be much less likely. So the opportunity for intervention for acute infection is actually very small. You would have to find the person and prevent the transmission event in a very narrow window of time, almost an impossible window of time. We'll come back to that in a second. Then we see people with high CD4 counts have a high blood viral burden, but a semen value that's probably not high enough to cause aggressive transmission, not at the level of acute infection. And then as the CD4 count falls, we again see this perfect extreme of higher HIV in the genital tract, more transmission probability, really really reproducing the epidemiology of the disease. Okay, so here's the deal. So we have a massive epidemic in Africa, and 80% of all the cases are in Africa and some other countries. And we understand a lot about the transmission of HIV, the biology of transmission, the cofactors that are driving the transmission, and we have really 2 things we have to do. We have to treat HIV, for reasons I'll get to in a second, and try and cure HIV. That should not be considered an impossible goal by anyone in this room. So that's part A. And part B is we have to use what we know now to try and prevent HIV. So I'm going to flip first to treatment, then to prevention. So for treatment, here's the bottom line. Look at the number of people who are dying in Africa from HIV, just massive numbers. And of the 16 million who died, 12 to 13 million died in Africa. And before 2000, it was believed that Africans either didn't deserve the drugs, or couldn't take the drugs, or couldn't tell time, or whatever. And in 2000, there was the first AIDS meeting in Africa. And at that meeting, most of the people in the room signed a document called the Durban Declaration. And Charlie, I think, was one of the leaders of the generation of that document, in which it said, look, these people are dying of a treatable infection, and it's just unreasonable or unacceptable. So that was 2000. Now, along the same lines, life expectancy is just devastatingly terrible in the absence of intervention with therapy, with treatment. So you see these countries, like Botswana is a rich country. People were living well into their 60s in Botswana before HIV. HIV takes over Botswana, lifespan goes down to below 50. You look at Malawi, a person born in Malawi today can only expect to survive to age 39. Now, how do you run a society when people are born, get through their secondary education, are going to die at age 40. You can't do it. It's like the Middle Ages. It reverses whole societies. So the only opportunity is prevention and treatment. And so the other issue from a social point of view is orphans. If one member of the couple gets HIV, the second member of the couple is at grave risk. It creates families where babies, whether infected or uninfected, are at grave risk of becoming orphans, therefore having to be raised by the village or by grandparents. So you go to villages where most of the people are living in conditions that demand intervention and are being raised by the village or by grandparents. So you have about a third to a quarter of the children in these countries are living as primary orphans. I will say that there's literature that says that the United States view of an orphan is different, and some people who work in Africa might argue about this, that the villages are saying, I hate to be Hillary Clinton-like, especially today, but this idea takes a village. One argument that's in the literature lately is that while we look a lot at no primary caregiver among our parents, that the children get better care than would occur in the United States because of the culture. And I don't want to get too much into that, I'm not an expert on it, but it's an argument. So we have these 16 drugs, and probably more by now, and these 16 drugs have been unbelievably life-saving. And most of the people in this room have been involved with the use of these drugs. And this is the use of ART, and this is the mortality in the West as occurred with the intervention of HIV therapy. So from our point of view, I've worked here now for 30 years, almost. In 87, we started a ward, 86, 87, the ID group started a ward that took care of HIV-infected patients. At that time, and those of you who, the pulmonary service will remember this well, 12% of all the patients in the hospital in 87 were HIV infected, 12% of all the admissions. We had something like 3 deaths a week, or 4 deaths a week. And it was just a terrible time to try and be an infectious disease specialist. And we had the nurses on the Med-K 6th floor service. Those dedicated nurses are the same nurses on that service today. Most of those nurses started with us because they wanted to take care of HIV-infected patients and infectious diseases, as well as pulmonary diseases, because that's a combined ward. And the intervention of ART made HIV treatment, made HIV an outpatient disease, a chronic outpatient disease in the United States, and not a devastating, rapidly fatal infectious disease. So as we started working in Africa, it was like all 1987 redux. It's just the same thing over again. Now, what's happened after 2000 is the recognition that millions of people in Africa, 5 million roughly, need antiviral therapy, and with contributions worldwide, shockingly, but wonderfully, about almost 2 million, 24% of the need is being fulfilled with donated drugs. So this is a big thing. They're going from no treatment in Africa to treatment. Now, the United States contribution is for all that we would beat up the United States about its failures, which we could do for a long time. The PEPFAR program has made a difference. There are 15 focus countries, but funds are available from this presidential emergency plan for 120 countries. These funds have been used to train lab personnel to provide care, not always ART, to more than 3 million people. The PEPFAR program is providing ART now to more than 600,000 people. In the budget for this year, $15 billion is allocated for PEPFAR. That is the contribution of the United States to sub-Saharan African country interventions. And Clinton and the Democrats, they want to make this $30 billion. So you see a real lot of money devoted to trying to improve the lot of the people living with this. There are other contributors as well, the Global Program, the Gates Foundation, and the 3x5 WHO program, but the U.S. is the lion's share of contribution, and about 1 out of 3 people on a planetary basis with HIV are receiving some sort of treatment or care support from the United States, which I think we should be proud of. So with respect to treatment, I'll say one last thing. That I think the people in the clinic would I think, agree that the treatments have gotten better, the drugs are much less toxic, they're much better tolerated, there's a million issues ongoing, but we need to try and cure this infection. My generation of investigators was told never to talk about curing HIV, which is like a shocking thing. So the cancer field, and I'm not trying to, it's a wonderful field, but they talk about race to the cure, run to the cure, crawl to the cure, any possible mobile thing they use. And I think that's good. They recognize, they have a mobility to curing cancer. But the physicians in this room would recognize that cancer is it's not one disease, and when they cure cancer, what they're really talking about is doing repeated testing over 10 or 15 or 20 years to see if there's a recurrence of the disease that they've treated, which is fine. HIV is the same. Why should we not have mobility to curing HIV? It's a daunting task because there are 2 daunting challenges with curing HIV. One is that it's compartmentalized. We have to get every compartment in the body affected with antiviral therapy. But that's what confronted lymphoma when I was a medical student. How do you get rid of lymphoma in the central nervous system and the testicles? And now that's not a big deal anymore. The second issue is integration of the virus. So David Margolis in our group, he's one of the leaders of trying to understand how you get HIV that's integrated out of integration so you can cure this infection. My prediction is in the next 10 or 15 years, you will see a massive attempt to cure HIV. And that's a really good thing. People should not be afraid to try that. The second thing we're going to talk about then, and probably the most important thing, is prevention. Before I should have one F. I'm learning to type with both hands. This was my first slide with both hands. You can see the problem. This is not good for my future. So opportunities to prevent HIV. Before exposure, the vast majority of our energies and our resources go to trying to prevent people from finding themselves confronting HIV virus. So all of this counseling, all this behavior change, everything is about uninfected people. Don't get HIV, don't get HIV, don't get HIV. Don't use needles, don't use needles, don't use needles. Don't have sex, don't have sex, don't have sex. And if you do, use condoms. At exposure, we have to prevent HIV, and our opportunities involve PrEP, which I'll talk about, and a vaccine, which doesn't exist. After exposure is PEP, which I'll talk about, and then there's positive prevention. This is everything on the planet for prevention on one slide. First of all, we know that if you control STDs, you do behavior change, and you use condoms every single time, no HIV will be sexually transmitted. You can still get drug use transmitted HIV from a needle. But this would work, but it's not very realistic for the whole species because you can't use condoms and have a baby. And so and condoms are a problem for many people to use every single time of intercourse. We'll talk about topical microtomes. The diaphragm trial, a trial was done to cover the cervix with a diaphragm. The trial failed to show any protection. So that taught us that either there's something wrong with the trial or HIV is not only transmitted through the endocervix, it must be transmitted through the vagina as well. Male circumcision we'll talk about, antiviral therapy we'll talk about. There's 2 ways you can use antiviral therapy. One is HIV antiviral therapy, which we are leaders in. The other is to try and treat herpes. What if you treat herpes in somebody who's HIV infected, or what if you treat herpes in somebody who's HIV uninfected? So 2 massive trials are going on to see what the benefit is of herpes intervention. And then there's structural interventions. Incentives for safer sex. In Malawi, girls receive money. If they remain uninfected, they get 3 months' salary. School uniforms make a difference in girls getting infected. Needle exchange is now available widely in China. widely in China and will be available in Washington, D.C. next year, because the federal government finally let Washington, a hotbed of HIV transmission, do needle exchange in that place. So there are many, many structural societal interventions possible. So let me say just a word about vaccines. The good news, HIV proteins are immunogenic. So you can put a protein in somebody's arm from HIV and you can see an immune response. And there's an animal success story which I'll show you in a second. The bad news is there's no reliable surrogate of immunity. We don't know how to create immunity that would prevent HIV. Any immunity we create so far has been short-lived. There are two giant vaccine trial failures, and then there's a cost-benefit ratio of disinhibition. If we make a vaccine that we put in somebody's arm, and we tell them that they have some protection from the vaccine, and they have more sex, they get more STDs, unless the vaccine is 100% protective, we would make the epidemic worse and not better, because rho equals beta delta C. So if we don't reduce the efficiency of transmission to zero, and there are more partners, we can make the whole epidemic worse. Does that make sense? Okay. So the vaccine story is all on this slide. Here's what we're supposed to do. We're supposed to take somebody who's infected, this is a person who's infected, we're supposed to vaccinate them so that at this moment in time when they're exposed, they can't get infected. They have sterilizing, neutralizing immunity. We don't know how to do this. So instead, what we spent not me personally, what the species has spent the last 10 years doing is this. They've taken materials, proteins, that cause an immune response, in monkeys at least, that make the monkey get infected, let the monkey get infected, but the monkey gets a lower peak viral burden, and the monkey gets a lower set point for 100 days. And the argument is that the monkey would be healthier, and the monkey would be happier, and the monkey would not infect other monkeys. So this has been the basis of the entire vaccine program in the United States. Not sterilizing immunity, which was said to be impossible, but instead a cell-mediated immune vaccine. Now, as many of you probably already know, the Merck 502 study, which was this vaccine, has been a disaster. How many of you are already familiar with this? Okay, so basically, this was an adenovirus vector with some stuff from HIV that was going to cause a CTL response, a cell-mediated immune response. The study was stopped because of futility, because it did not cause any reduction in peak viral load. It didn't do this. It didn't do this. And, well, actually, this was not studied. They don't know how to study this. It didn't do this. And, in fact, the people who got vaccinated, some of the men had a higher likelihood of getting HIV than if they had not been vaccinated. You can imagine this caused some consternation at the NIH and in Merck. So I don't know where this is going. There's another vaccine called PAVE 100 that we're supposed to participate in. Chris Patterson is leading our local PAVE 100 effort. Is that correct, Chris? And it is going to go forward in some fashion, but how it's going to go forward, we're not sure, and we'll keep you informed as we decide what we're going to do. Now, the great hope, I think, for vaccines, or maybe a great punishment for UNC, is called, not a punishment, a gift to UNC, is called the CHAVI, the Center for HIV Vaccine Immunology. This is the world's biggest grant. This was the U.S. government saying, we're getting nowhere fast in vaccine efforts. We need to give a huge amount of money to vaccine development. And so there was a competition. And the competition was won by Duke, UNC, Harvard, Oxford, and Alabama. So I have the privilege of being one of the 5 leaders. Duke is the overall leader of this effort. The CHAVI is supposed to have no presumptions and no assumptions. The CHAVI is supposed to make a vaccine in 7 years. The CHAVI has focused all of its efforts on neutralizing antibodies and 3-dimensional structure of HIV, and gone back to the drawing board and said we have to make a preventive vaccine, not a failed T-cell vaccine. The CHAVI gives great pain to Gene Oranger, not to focus on him, because Bart Haynes, the leader of the CHAVI, not surprisingly, because we had a $300 million award, is the #1 investigator in the United States for NIH funding at $48 million a year. Now, UNC gets a lot of that money, so we love Bart. So there's no reason to criticize Bart. We don't get credit. We don't get credit, as Gene points out. Hence, we're 11th instead of 10th. Okay, so the CHAVI, many people in this room are aware of the CHAVI. The CHAVI is a huge effort to make a vaccine in 7 years with no presumptions, and I'll report to you in 7 years. Circumcision, where is my foreskin? This is a really big deal. So it was recognized for a long time that HIV seroprevalence was inversely correlated with circumcision, where people were circumcised a lot, like in the United States and in Europe, and in some parts of Africa where there are a lot of Muslims, there was very little HIV. And where there was less circumcision, there was a lot of HIV. And this would be rational because the skin is incredibly wonderful to prevent infection, and the foreskin is kind of this thin, paper-thin, but don't raise your hand if you're circumcised or uncircumcised, but those of you who've seen foreskins recognize it's this paper-thin layer that gets a lot of inflammation and also has a ton of dendritic cells, which are the cells that HIV wants to find to infect. So covering the glands of the penis with skin is a really great idea. And when you circumcise somebody, you cover their glands with skin. You also reduce the STDs, and not surprisingly, circumcision works. So there are 3 randomized trials. All of them were stopped prematurely because all of them worked and caused anywhere from 50 to 70% reduction in acquisition of HIV. So modeling says that if you circumcised all the men in Soweto, a hotbed of HIV, that you could drastically reduce new infections of HIV in circumcised men, and a lot of men in Africa are being circumcised volitionally because they really want to reduce their probability of getting HIV. But the problem is, let's be realistic, can we circumcise our way out of this epidemic? Are there enough urologists or morals or Muslim? You can't train enough of these people. Also, there's complications of circumcision, as any pediatrician knows. And beyond that, there are huge cultural barriers to circumcision. Hindus aren't going to be circumcised because they'd be viewed then as Muslims in India. So getting Indians to embrace circumcision is not going to happen overnight, if ever. Chinese have their one-child policy. They want to have a boy. The one baby boy is born. They don't want anything done to the one precious baby boy. So going to the Chinese and saying, start a circumcision, is this a microphone doing something weird? No. Well, it is to me. So Chinese are not likely to circumcise themselves overnight either. So that brings us to what we actually have available to us right now, today, which is antiviral therapy. So first of all, you could use antiviral therapy as a topical microbicide. And so the hottest kind of area, the hottest topic in the topical microbicide field is taking the antiviral drug tenofovir, which many of you have used for patients, putting it in a gel and putting it in a vagina and trying to show that tenofovir will stop acquisition of HIV by a woman who uses this gel. So this trial is going to happen in the United States and Africa. It's all over the world. It's called the VOICE trial, and that trial will start this year. Then you have 3 uses of oral agents. You could use the oral agents as post-exposure prophylaxis, as pre-exposure prophylaxis, or for treatment of the infected person. For post-exposure prophylaxis, we can never do a clinical trial. So instead we made guidelines, since we never could do a clinical trial. These are the guidelines. If you're exposed to HIV, whether by a needle stick or through sex, you have a narrow window of time to get treatment. This is a real emergency. The outer limit is 72 hours. But usually you would want minutes to go by before you would take antiviral therapy. And so you start the antiviral therapy as fast as you can if you think significant exposure has occurred, and you continue it for 28 days. Because in the animals, if you don't continue for 28 days, then what happens is the monkeys go on to get infected. So you've got a post-exposure window, emergent, and you take drugs. Now, the CDC doesn't know what drugs you should take or how many drugs to take. And so what we recommend, of course, is like community-based solutions. But most people will get triple drug therapy. Angela Kasuba, who I mentioned earlier, and other collaborators of hers, including me, have done these studies of the pharmacology. This thing is like a mess, sir. Can I use this? Does this work? Gene said to tap on it. Thank you, Gene. So, except I've lost my lecture. What happened to that? I get the microphone, but no slides. Well, everything was going perfectly until that moment. At least for me, it was going perfectly. I will continue to talk in case we'll never see these slides again. So post-exposure prophylaxis we've talked about. This is really important for the house staff. The emergency, don't waste any time. Take 3 drugs right away. If you see a woman who's been raped, the other thing is don't tell a woman who's been raped, think about it and come back 2 days later. This is a real big medical emergency. Start the drugs and make a decision later whether you want to continue the drugs for the full 28 days, but don't hesitate to give the triple drug therapy. And what Angela's done is shown that not all drugs are created equal. The drugs on the left don't find their way into the female genital tract. You see the drugs on the right concentrate in the female genital tract. So if you're choosing drugs for a rape victim, you will choose drugs that emergently concentrate in the female genital tract. The hottest topic in antiviral therapy is about pre-exposure prophylaxis. It's called disco drugging. Could you know you're going to go have risky sex and take pills just before you have sex and just after you have sex? Well, we don't know that, but these are the monkeys that have been studied. And you see the bottom line is all the monkeys getting infected. All the monkeys getting infected over 14 weeks without antivirals. When you inject supratherapeutic concentrations of tenofovir and FTC, Truvada, you protect all the monkeys. When you take oral Truvada, you protect 80% of the monkeys. This paper is coming out in PLOS Medicine next month with an editorial by Angela and I, and it talks about the importance of this observation and what kind of public health implications this might have if pills could be taken before and after HIV exposure. So we'll call that pre-exposure prophylaxis. Here, one trial for safety has been completed by Family Health International by Lee Peterson, and the drug proved to be safe, and there was a hint that they were seeing protection, but the study was never powered to see protection. Because this can be done, these are all the studies being done. CDC, NIH, studies of pre-exposure prophylaxis all over the world, and studies planned. Gates Foundation, NIH, and USAID will do a study in Malawi of high-risk women with Irving Hoffman leading and others leading this study. So we will know in a couple of years whether pre-exposure prophylaxis actually works. I'm going to skip that. The most important thing, of course, is what happens when you give a patient antiviral therapy. Do you render the patient less contagious? We have biological plausibility, expectations from the literature, and a clinical trial that UNC is leading. So this is what happens when you start the therapy. This is one of our many, many studies of this. You take a person before therapy, you can easily detect HIV in semen, you start therapy, and only in 1 out of 114 patients could we detect HIV in semen. We haven't cured them, but we've rendered the semen much less rich in HIV. Many studies in the literature, I won't bore you with them, suggest that antiviral therapy probably has an effect on preventing HIV transmission. One study is important. Becky Bennell in Uganda studied 454 subjects, cohabitating partners, high viral load in the baseline patient, started therapy in the baseline patient, did an observational study. She expected to see a lot of HIV seroconversions. She saw only 1 seroconversion over 2 years in the people that were taking the therapy. So the implication is if a person went on therapy, their partner became much less at risk of getting HIV. But these are observational studies. Everyone believes you need to do a clinical trial. So this is a massive clinical trial to start antiviral therapy early. So 350 to 550 cells, you start it early or you defer it, and you're studying a couple. It's called HPTN-052, and the endpoint is can you block a transmission event in the partner? And you're also learning a lot about early antiviral therapy and about antiviral toxicity and early treatment. This study takes a long time to do and costs $100 million, so don't wait till tomorrow to see the result. So the bottom line about prevention is that we know, I've told you everything that's being done in prevention, and this slide generated for the Gates Foundation tells you exactly when we're going to know the results. You see, the male circumcision stuff is done. We know it works. Oral prep safety is done. We know it's pretty safe. Diaphragm is done. We know it doesn't work. Male circumcision for infectiousness was stopped because the men were having sex with sutures in and infecting their partners. So this study has been stopped. What did I do here? This is your fault, sir. It's Gene's fault. I cannot be to blame.
You're just a little too close to the podium.
You know how to fix it.
I think this is what I just pushed.
The most important slide, too. This is the last slide, so don't be anxious that you won't get out of this room. Everyone gets out. Okay, so I'm going to tell you that on that last slide, which might or may not reappear in this lifetime, Yeah. Okay. On this last, I'll stay away from the podium. On this last slide, you see this community VCT and support study is being completed in 2008. It's a giant study of behavior for a community. HSV-2 treatment. If you treat a person who's HIV negative but HSV infected, do you make them less susceptible? This result will be announced at CROI next month. This study is done. So we're going to know whether antiviral therapy for herpes does anything. Treating somebody with herpes, we'll know that in 2009. The first oral pre-exposure prophylaxis study being done in Thailand in drug addicts, done in 2009. The microbicide studies done in 2009. This vaccine study is stopped. This vaccine study is stopped, so there's no vaccine results in the foreseeable future. These other oral pre-exposure prophylaxis studies done in 2010, and then the study UNC is leading called 052 will be done in 2012. So if you're in the HIV prevention field, everything is known what's going to happen. There's not a lot of unknowns. And so all we can do is what we're doing now. And what I can say is we've made a lot of progress, but this, if you decide to do this for a living the rest of your life, you'll have a job the rest of your life. This isn't going away. And so I guess I should end this and answer any questions for a couple minutes by thanking all the people. UNC, as I said, is one of the great, eighth, I'll round off to fifth. One of the 5 best places in the United States or the world for HIV research. There's a really dedicated team of caregivers and investigators that have worked together for 20, 30 years, all on this problem. It's not going away. I want to thank all of them and thank you for listening. My colleagues may disagree with 90% of what I said. Does anybody want to correct anything I said totally wrong or ask any questions? Because we're right. Yes, Becky, you want to make a correction?
No, I have a question. Often when we're on the consult service, we get called about someone who's been raped, a woman usually, and is past the 72 hours in terms of post-exposure prophylaxis. Let's say day 5.
There's no benefit. In the animals, there's been no benefit.
But now, based on your expertise,
no benefit.
There's no benefit at all.
At least the only data we have are animals. So starting somebody on toxic, expensive drugs, when even animals couldn't be protected under controlled conditions, I don't see that I would do it. I would say, look, there's no benefit, and I'm sorry. It's the same as many other infections that we try and prophylax. The zoster, we try and treat emergently, but within 2 to 3 days. If it's more than 3 days, the benefits of acyclovir are reduced, right? So I think we have to accept the reality. Other questions or comments? Yes. Christopher.
All of your focus was on biomedical interventions, and I just wanted to point out, our clinic has several large behavioral things.
I'm going to repeat what you said. So Chris's point, which I think is extremely important, is for me, I'm a biologist. I'd like to be at least. And so I'm focusing on the things that I've worked on pretty aggressively. Chris's point is that the majority of the prevention field is actually behavioral. Most of the resources are behavioral resources. And in our clinic, the people working in the clinic have done a great job at doing a variety of studies with Ryan White money and CDC money in trying to understand what can be done for people who are negative to keep them negative and for people who are positive to help them not infect somebody else. And so Chris is emphasizing that. And a lot of this has to do with behavior change theory and work. So thank you, Chris. Other comments or questions? Okay, you're free to go. Thank you.